Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Long-Term Outcome of 138 Adults with Systemic Anaplastic Large Cell Lymphoma Treated Within the GILA Trials by David Sibin and colleagues. My name is Carrie Savage, and I'm an Associate Professor of Medicine at the University of British Columbia and a medical oncologist at the British Columbia Cancer Agency. My oncologic specialty is lymphomas. Anaplastic large cell lymphoma, or ALCL, was initially described by Stein et al. In 1985 based on characteristic anaplastic tumor cell morphology, a tendency to grow cohesively and to invade lymph node sinuses, in addition to strong uniform expression of the key 1 antigen, or CD30. In the WHO classification, ALCL was limited to those with a T cell or a null cell phenotype, and systemic ALCL was distinguished from primary cutaneous ALCL due to differences in clinical behavior. ALCL was further characterized by the identification of the NPM ALK fusion gene associated with a non-random 2-5 chromosomal translocation. Other less common partnered chromosomes have since been identified. However, ultimately, a fusion protein can be detected in 60 to 85% of cases of ALCL using a monoclonal antibody to the ALK-protein in paraffin-embedded tissue, and these cases are designated as ALK positive. ALK positivity is seen more frequently in childhood and in young adults, thus the frequency can vary depending on the population studied. ALK negative cases are morphologically similar to those that are ALK positive, however they lack the ALK protein, and the small cell variant is not recognized. More recently, comparative genomic hybridization and gene expression profiling studies have also established the distinct nature of the systemic ALCL subtypes. The updated WHO published in 2008 defined ALK-positive ALCL as a distinct entity and ALK-negative ALCL is a provisional entity. Multiple small studies have established that cases of ALCL that are ALK-positive have a more favorable outcome than those that are ALK-negative, even surpassing diffuse large B-cell lymphoma, at least in the pre-rituximab treatment era. In some studies, the prognostic importance remained independent of the International Prognostic Index, or IPI. However, 2 recent studies are challenging the independent effect of the ALK phenotype and suggest that age is a critical component impacting outcome. The International T-cell Lymphoma Project was a large collaborative retrospective study evaluating the pathologic and clinical features of the peripheral T-cell lymphomas. The subgroup of ALCL patients was reported in the Blood Journal 4 years ago, and similar to other reports, found a superior outcome in ALK-positive compared to ALK-negative patients, with a 5-year overall survival of 70% and 49% respectively. Although this study did not specifically readdress the impact of ALK positivity as an independent prognostic factor, a separate analysis was performed in patients less than 40 and greater than 40, and in these subgroups, the ALK status did not impact outcome, suggesting that age is a predominant factor driving prognosis in ALCL. In this issue of the Journal of Clinical Oncology, Sibin et al. Performed a retrospective study evaluating 138 patients with systemic ALCL that had been enrolled on completed prospective GILA studies. Importantly, all cases were re-reviewed by expert hematopathologists. In this series, 46% were ALK positive and 54% were ALK negative. The median age in the ALK positive group was 31.5 years, and in the ALK negative group, it was 56 years, which is similar to that reported in the International T-cell Lymphoma Project. Consistent with prior studies, the overall survival was superior in ALK-positive cases, with the authors reporting a 5-year overall survival of 86% versus 58%, and an 8-year overall survival of 82% versus 49%. Of note, the 5-year overall survival estimates are superior to that reported in the International T-cell Lymphoma Project, which is likely due to a combination of selection of good-risk patients, as 3/4 had a performance status of 0 or 1, in addition to the fact that this cohort was derived from patients entered into a variety of clinical trials, including some incorporating high-dose chemotherapy and autologous stem cell transplant. The authors' main focus was the exploration of prognostic factors in ALCL patients. They did a detailed analysis of the prognostic impact of age and found that a cutoff of 40 was optimal. Although there were only 17 patients in the ALK-negative ALCL group less than 40 years of age, ALK status did not impact progression-free survival or overall survival in this defined younger population. In contrast, for patients over 40 years, progression-free survival and overall survival was superior in ALK-positive patients. Similar to other studies, the IPI was also useful in dividing patients into risk categories. Although in ALK-positive ALCL patients, it was not statistically significant, which may reflect the dose-intensified regimens as well as the predominance of patients in the low IPI risk groups. Exploration of other clinical factors in all ALCL patients revealed that an elevated beta-2 microglobulin was associated with a poor prognosis, along with age greater than or equal to 40 years, but ALK status was not. The evaluation of prognostic factors within ALK-positive and ALK-negative ALCL also revealed some differences, where only multiple extranodal sites was relevant for overall survival for ALK-positive ALCL, and no factors important for progression-free survival. In contrast, beta-2 microglobulin and hepatic involvement were associated with an inferior progression-free survival in ALK-negative ALCL, and these factors, along with a low albumin and the IPI, were significant for overall survival. Using age and beta-2 microglobulin level, divergent risk groups in ALCL emerged with a 5-year overall survival ranging from 84% to 22%. However, this was only relevant if evaluated in the whole group and not in the individual ALK-positive and ALK-negative cohorts. How do we move forward from this study? It is clear from prior studies that there are biologic and genetic differences between ALK-positive and ALK-negative ALCL, and they should continue to be considered separate entities. It is anticipated that ALK-negative ALCL will move from a provisional to a distinct disease in the next iteration of the WHO classification. The present study, along with findings from the International T-cell Lymphoma Project, suggests that rare patients with ALK-negative ALCL that are less than 40 years of age may have a similarly favorable outcome as younger patients with ALK-positive ALCL, although it is worth noting that this represents a small number of patients and a detailed account of the treatment these patients received is not outlined in this paper. The relevance of an elevated beta-2 microglobulin is of interest, as this marker has been identified in a variety of lymphomas as impacting outcome and awaits verification in other databases. This study emphasizes the importance of age and other clinical factors in addition to the ALK status when predicting outcome for individual patients and for trial comparisons. Studies evaluating new treatment approaches and novel regimens need to consider these variables for trial eligibility and stratification. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.